Yeah, for some reason, my Zoom account on my laptop is not, I don't know, it's not working. So I will be sitting in for Dr. Thomas today, who is probably sitting, I hope, on his balcony, looking at the ocean and not doing email.
Good for him.
So good morning, Dr. Sparano. Thank you for doing this today. So what time is it? It's 8:31. Maybe one more minute and then you take it away, Emily.
Okay.
I think we should go ahead.
Okay. Thanks, Dr. Asher. Good morning, everyone. Welcome to Grand Rounds. Today, we're joined by Dr. Joseph A. Sparano, who is the Ezra M. Greenspan Professor in Clinical Cancer Therapeutics, Chief of the Division of Hematology Oncology, and Deputy Director of the Tisch Cancer Institute. He's a medical oncologist whose research is focused on clinical application of biomarkers in breast cancer and developmental therapeutic approaches for breast cancer, lymphoma, and HIV-associated cancers. He also currently serves as Deputy Chair of ECOG ACRIN and is the Principal Investigator and Group Chair of the AIDS Malignancy Consortium and is a recipient of funding from the U.S. National Cancer Institute and Breast Cancer Research Foundation. Thank you very much for joining us, Dr. Sparano.
Thank you. It's my pleasure to be here. I'll start with just a brief review of my financial disclosures, including from industry and the funders who've supported some of the work I'll share with you. The educational objectives are summarized on this slide. I'll be reviewing three major themes, that is progress, precision, and equity in cancer care. And I'll start with progress. Firstly, in terms of the cancer burden and mortality in the United States, as you know, cancer is the second leading cause of death behind heart disease and now above COVID-19, which has emerged as the third leading cause of death. The good news is that cancer incidence and mortality has been declining for the last 30 or 40 years. And this slide on the bottom right depicts the number of cancer deaths that have been averted because of this progress that has been made. Much of this progress in declining cancer mortality has been the result of more widespread use of screening, particularly for breast, prostate, colorectal, and cervical cancer, reduced smoking rates and use of tobacco, but also the more widespread application of adjuvant systemic therapies in patients with localized disease treated with primary surgical therapy, and the emergence of new, highly effective new therapeutic agents. This curve or this graph shows the annual number of new molecular entities and biological licensing applications approved by the FDA over the last 30 or so years. And you could see this escalation recently with about 50 new agents approved annually. And as you can see, about a third of these agents in 2021 and over the last 5 years have been in oncology. I'm now going to hone in specifically on breast cancer, my area of interest, and review the factors contributing to declining breast cancer mortality. There's been a 40% decline in mortality rates. And as I mentioned, this has been due to more widespread mammographic screening and early detection and the application of adjuvant systemic therapies. We also have better and less morbid local therapies. We've been able to de-escalate surgery from mastectomy to now wide local excision, and from axillary dissection now just to central node biopsy. We have better radiation techniques that result in better local control of disease and fewer long-term complications. We also have access to better molecular testing, such as fluorescent HER2, fluorescent in situ hybridization for detection of HER2 amplified tumors. We can identify germline pathogenic variants that predispose to an increased breast cancer risk, for which we now actually have therapeutics. And we can also identify somatic activating mutations in patients with advanced disease to target specific therapies. And this depicts on the right the number of systemic therapeutics we now have, including cytotoxic agents, anti-estrogenic agents, anti-HER2 directed therapeutics, antibody drug conjugates that can deliver a toxic payload specifically to tumor cells bearing specific epitopes. We now can harness the effects of the immune system with immune checkpoint blockade with antibodies targeting PD-1 and PD-L1. There are agents targeting poly-ADP ribose that can be induce synthetic lethality in individuals harboring cancers associated with germline BRCA1 or 2 mutations. We also have agents that can target activating somatic mutations such as PIK3CA inhibitors, with alterations of PIK3CA being the most common alteration in breast cancer. A critical concept in the evolution of cancer therapy was proposed by the late Bernard Fisher, a surgeon, who posited that breast cancer is a systemic disease from inception. And this was a radical and paradigm shifting concept when it was initially proposed, because up until that time in the 70s, there was the Holstedian approach to cancer therapy was followed, whereas more and more local therapy, surgical therapy, and debilitating therapy was used to try and get better systemic control of disease. Dr. Fisher proposed that tumor cells can seed the circulation into the circulating blood, and also the lymphatics, which can then seed the circulating blood. But evidence from the clinical trials that he led with 20 years of follow-up indicated that there was this inexorable annual recurrence risk after local therapy for breast cancer, whether that local therapy included total mastectomy, lumpectomy with an axillary dissection, or lumpectomy with radiation, providing proof of principle of his concept. And that concept or the principles have evolved since that time. And we now know that there's evidence suggesting that there may be minimal seeding from axillary lymph nodes, and much of this seeding may actually be directly from the tumor into the systemic circulation. In addition, there's now evidence that tumors can self-seed, that is, that a tumor can seed the circulation and then seed the primary tumor, which can induce epigenetic and other changes that promote further seeding. And then you can also have secondary seeding from distant metastatic sites. And I'll get back to this concept later. Building upon this concept and progress was the concept espoused by the late Johnny Bonadonna, a medical oncologist, that adjuvant systemic therapy in early breast cancer could help reduce the risk of recurrence. If indeed patients had systemic occult metastatic disease that could not be identified, then perhaps administering cytotoxic therapy in this early pre-clinical stage could help reduce the risk of recurrence. And in fact, this was initially proven back in 1976. In addition, Dr. Bonadonna was promoted the notion of combination chemotherapy and used this to affect in treating and curing Hodgkin's lymphoma. And this same principle was applied to the treatment of early stage breast cancer. Fast forward approximately 30 years, or actually at about that time, that Dr. Bonadonna promulgated this and made this initial discovery regarding the role of adjuvant chemotherapy. Dr. Susan Horowitz at the Albert Einstein College of Medicine identified that a natural product derived from the bark of a yew tree, Taxol, can promote microtubule assembly and could actually have anti-neoplastic effects. And fast forward 30 years later, it took about 30 years to prove that this, the use of this drug in the adjuvant setting for early stage breast cancer could help reduce the risk of recurrence, specifically and especially in patients who had triple negative breast cancer, that is, tumors that lack the expression of ER, PR, and HER2, which accounts for about 15% of all breast cancers, more common in younger women and Black and Hispanic women, and characterized by earlier time to relapse, and for whom we have no specific targeted therapies up until recently. And in this particular case, we demonstrated that the administration of paclitaxel on a weekly basis was associated with better outcomes than other taxane schedules of taxane administration. So this progress within 25 years of Dr. Bonadonna's original report led to the demonstration that adjuvant chemotherapy was recommended for most women with localized breast cancer based on a US NIH consensus panel convened about 20 years ago. And it was based in part on the totality of evidence that was present at the time, but also on evidence from clinical trials, even in patients with low risk lymph node negative, axillary lymph node negative breast cancer, indicating a beneficial effect of chemotherapy. Well, the price of progress was both the short and long-term complications of chemotherapy used in a potentially curative setting. These include the typical well-known complications of chemotherapy, including nausea, vomiting, alopecia, immunosuppression, and rarely patients can die from the cytotoxic therapy. There are also long-term adverse consequences such as neuropathy, infertility, and leukemia, MDS, and cardiomyopathy with certain agents. There's also this issue of overtreatment in that some patients would be cured with just local therapy alone. And so for those patients, we are unnecessarily administering this chemotherapy. And there are issues related to cost, financial toxicity, the cost of treatment, the disruptions in the ability to work, and the resulting loss of income. So we clearly needed better precision in cancer therapeutics. And up until, I would say, the last 15 years, the major principle in treating a patient with adjuvant therapy with early breast cancer was prognosis. In other words, we recommended chemo based on those individuals who had a higher risk of recurrence based on clinical pathologic features such as nodal status, tumor size, and grade. And in this case, if one applies an adjuvant therapy, one will see an improvement in therapy at all risk levels, but one can't really distinguish which patients are deriving benefit. So that the higher the underlying risk of recurrence for those patients on the right-sided part of this curve derive greater absolute benefit than those who have a lower risk of recurrence. Within the last 20 years now, we've used biomarkers such as the expression of the estrogen and progesterone receptor, protein expression, and HER2 protein expression or gene amplification to identify patients who can benefit from specific therapies. So we can now identify who is benefiting from specific therapies. And these biomarkers have an essential role in the management of early breast cancer and a variety of cancer types. But in order to rely on these markers, one needs to assure that they meet certain criteria. Firstly, there needs to be analytic validity. That is, the assay needs to be reliable and reproducible. Second, there needs to be clinical validity. That is, the association with a biomarker result and a clinical outcome. But thirdly, and most importantly, and this applies to some of the gene expression profiles that I'll describe to you in a minute, there needs to be a value in the management of patients in guiding treatment, which is associated with an improvement in clinical outcomes. And these criteria are derived from the EGAP guidelines, which were specifically derived to provide a guidance or framework for the use of gene expression profiling in early breast cancer and other cancer types. And just to point out that there are specific guidelines for the use of HER2 testing and estrogen and progesterone receptor testing. So here's one example of precision. That is that hormone receptor expression is predictive of benefit from adjuvant anti-estrogen endocrine therapy, namely tamoxifen. So moving from the left to the right, you see greater benefit from tamoxifen in those patients who have estrogen receptor positive disease and less in those who have estrogen receptor positive, progesterone receptor negative, very little benefit in estrogen receptor poor disease, and no benefit in patients who have ER and PR negative disease. The second example of precision is HER2 overexpression, which is predictive of benefit from anti-HER2 therapy when used in the adjuvant setting. The figure on the right shows the time to recurrence for those treated who had HER2, specifically had HER2 overexpressing disease. This is a meta-analysis of nearly 14,000 patients, demonstrating that the addition of trastuzumab to chemotherapy could reduces the risk of recurrence by about 1/3, resulting in a 10-year gain of about 9%. The figure on the right shows that the same therapy, trastuzumab, in a prospective randomized trial had no beneficial effect in patients who had HER2 non-amplified disease, but low levels of protein expression. The third example of precision is the activity of inhibitors, PARP inhibitors in patients who have breast cancer associated with pathogenic germline variants in BRCA1 or 2 that are associated with a marked increase in breast cancer and ovarian cancer risk. The use of PARP inhibitors in this population, in these patients can induce synthetic lethality, specifically in the tumor by blocking a second mechanism of DNA repair, with one mechanism of DNA repair already being knocked out by the absence of a functional protein. And here you can see when used in metastatic breast cancer in patients who had germline mutations, this particular drug, olaparib, had only a very modest effect in improving progression-free survival. And this was based on a blinded independent central review of imaging studies. And this study here on the left led to FDA approval. Even though the drug did not improve overall survival, it improved a clinical endpoint of progression-free survival. The figure on the right shows that the use of the same agent, which was only marginally effective in metastatic disease, actually had an improvement in invasive disease-free survival when used in early stage breast cancer in patients who harbored BRCA1 or 2 mutations. And in fact, the FDA just approved olaparib in the adjuvant setting in patients with BRCA1 or 2 mutations last Friday. I'd now like to move on to the use of gene expression assays, which I would consider the third generation of biomarkers to guide the use of adjuvant chemotherapy. Recall that I previously pointed out that up until recently, recent being the last 15 or so years, we've recommended chemotherapy solely on the basis of a patient's underlying risk, and we dialed down that risk level so that even patients who had relatively low risk of recurrence, we were recommending adjuvant chemotherapy such that the absolute benefits were in the range of only about 3 to 4%. So we were over-treating many patients. What made this possible, one of the first reports was a gene expression assay in breast cancer was an unsupervised analysis demonstrating that breast cancer is a heterogeneous disease with distinct subtypes whose prognosis varied by subtype. And subsequently in supervised analyses where gene expression patterns were compared in patients who relapsed versus had no relapse, there were several prognostic assays that were developed, and it was shown that there was a lack of concordance in the prognostic classification by these assays. One of these assays was the 21 gene expression of recurrence score, or Oncotype. And shown here is The genes that are involved in this assay, including 5 genes that reflect proliferation, 4 that reflect estrogen receptor signaling, 2 that reflect HER2 signaling, 2 invasion, and 3 other individual genes. The expression of these genes is normalized relative to a reference range and then plugged into a coefficient. So you can see that those genes reflecting proliferation drive the score up. They're associated with a positive coefficient, and the proliferation coefficient has the highest number associated with it. So this really drives the score up. The HER2 group, you can see, also drives the score up, whereas the ER score drives the score down. And this is in the presence of anti-estrogen therapy, which is helping drive this more favorable prognosis. You could see these other individual genes also had some prognostic effect, either in a positive or negative direction, but the coefficients are less having a less dominant effect on driving the score. And in the original cut points that we used, patients were classified as low, intermediate, or high risk based on recurrence scores in these ranges. And then we embarked on a large randomized clinical trial that where we adjusted these ranges to try and refine the prognostic and predictive ability of this assay. The first evidence that provided level 1B evidence in estrogen receptor positive node negative disease was a prospective validation of the 21 gene recurrence score for prognosis. And this showed that overall, if you look at the proportion of patients who had a low, intermediate, or high recurrence score by the original definitions, about 50, 25, and 25% of patients fell into these 3 groups. And the 10-year risk of distant recurrence for those who had a low, intermediate, and high recurrence score was 7, 14, and 31%. Well, that's important, but the game changer, and this was remained significant in a multivariate model, and it was independent of age and tumor size. But the game changer came when it was demonstrated that high recurrence score greater than 25 was predictive of chemotherapy benefit in a HER2 negative population. So here, the 10% of patients who had HER2 overexpressing disease were excluded. And that was because at about this time, HER2-directed therapies became a standard part of adjuvant, addition to adjuvant chemotherapy. And so you can see these patients have a hazard ratio of 0.27. So rather than having about a 25% reduction in the risk of recurrence from the addition of chemotherapy, they have a 75% reduction in the risk of recurrence. And this translates into about a 25% absolute improvement in disease-free survival, which was statistically significant. In addition, the lower recurrence score was predictive of benefit from tamoxifen, again, because high ER signaling is driving the prognosis here in estrogen dependence. When this assay became commonly used in clinical practice in situations where there was therapeutic equipoise in estrogen receptor positive, HER2 negative, node negative breast cancer, which accounts for about half of all breast cancers in the US and about 8% of all cancers in the US, it was found that the majority of patients, about 2/3, had a recurrence score that was in the mid-range between 11 and 25. And there was still therapeutic equipoise about the value of chemotherapy. So back in around 2005, we designed a trial that was designed to address this conundrum. The population included patients with node negative, ER positive, HER2 negative disease, basically stage 1 cancer. And there were about 10,000 patients enrolled in this trial. And for those patients in whom we had evidence, level 1B evidence, where we were confident in the recommendation, we guided these patients to endocrine therapy alone if the recurrence score was low, or chemo plus endocrine therapy if the recurrence score was high, based on the data that I just showed you. And for the remaining 2/3 of patients where the recurrence score was in the mid-range, we randomized those patients to the standard arm, which was endocrine therapy plus chemotherapy, or to the experimental arm, which was endocrine therapy alone. And we used a non-inferiority design with a hazard ratio margin of 1.332, and we expected full information after 835 invasive disease-free survival events. We had the first results for the low-risk registry back in 2015 when we showed that in the 16 or 17% of patients who had a recurrence score of 0 to 10, who were prospectively assigned to endocrine therapy alone, they had only about a 1% risk of, less than 1% risk of distant recurrence at 5 years. Another key point here is you'll notice that the invasive disease-free survival rate is about 94%. So in other words, for every one distant recurrence, there was about 4 or 5 non-recurrence events, either, either a local regional recurrence or a contralateral breast cancer or a second primary breast cancer or death from other cause. And this information was published and it was integrated into the 8th edition of the AJCC into a prognostic staging for the first time in early breast cancer. We then had the results from the primary trial results in the randomized group after 836 invasive disease-free survival events. These events included distant or local regional recurrence, second primary cancer, or deaths from other cause, after a median of 7.5 years. And of these, about 40% of these patients had recurrence as the first event, of which about 25% was a distant recurrence. And we demonstrated for the primary endpoint non-inferiority for invasive disease-free survival and non-inferiority for distant relapse-free interval. So the primary trial endpoint was met, and we changed the standard of care by demonstrating that chemotherapy was unnecessary for about 70% of all patients with early breast cancer. We also followed patients assigned to chemo plus endocrine therapy who had a high recurrence score. And we found that these patients had a worse outcome compared to those who had a low recurrence score, irrespective of therapy, despite the use of adjuvant chemotherapy. So the question is, how would these patients have done had they not received chemotherapy? Well, this is not a substitute for a randomized trial, but we simulated what the outcomes would have been in this population based on the treatment effect for chemotherapy we saw in the earlier B20 cohort. And what we see here for patients who had a recurrence score of 26 to 30, which accounts for about 40 to 50% of patients who have a high recurrence score, there's about an 8% absolute improvement in invasive disease-free survival. And for those who have the remaining half who have a higher recurrence score, there's about a 30% absolute improvement. So very substantial improvements. Some of the other key findings from this trial are shown here. First, clinical pathologic factors added to the prognostic information, but were not predictive of benefit for chemo. Second, there was no chemo benefit in both the low or the high clinical risk groups as defined here. And thirdly, we saw statistically significant chemo treatment interaction. There was a two-way interaction between age and chemo benefit and a three-way interaction between age or menopausal status, recurrence score, and chemotherapy benefit. So that for patients who were under the age, who were 50 or under, who had a recurrence score of 16 to 20, they had about a 1.5 to 2% absolute improvement in distant relapse-free survival at 9 years. And for those who had a recurrence score of 21 to 25, fairly substantial benefit of about 7%. When we looked at this as a continuous variable, adjusting for tumor size and grade, again, we see no benefit at all for women over 50, but we do see these curves diverge, the endocrine therapy alone curve versus the chemoendocrine therapy curve, indicating there's some chemo benefit within this range. And in fact, if we look at population-based data, we see a similar phenomenon where there is a chemotherapy benefit emerges at a different recurrence score cut point for women over the age of 50 compared with women 50 or under. And if we compare the outcomes in the TAILOR-X, so-called TAILOR-X trial, we see, again, benefit for women who are 50 or under and premenopausal have a high clinical risk, but no benefit in older women. The same was true in another trial using a different gene expression profile called the MINDAC trial. And also a similar effect was seen in another trial called the RESPONDER trial, where we used the same 21 gene recurrence score, but now tested this in patients with 1 to 3 positive nodes. And here you can see there's a chemo benefit in the range of about 5 to 6%. What's driving this chemo benefit? Well, it may be the chemotherapy-induced early menopause. There is data from previous studies demonstrating a benefit for those patients who developed amenorrhea compared with those who do not develop chemotherapy-induced amenorrhea, in both overall survival on the left and disease-free survival on the right. And on the bottom, you can see this benefit is seen only in patients who have hormone receptor positive disease and not in patients who have hormone receptor negative disease. So we really need a trial to address this remaining knowledge gap in premenopausal women who have a high clinical risk and a low genomic score, comparing ovarian function suppression, essentially complete estrogen blockade with ovarian function suppression and an aromatase inhibitor versus chemotherapy plus the same endocrine therapy. This trial was attempted approximately 20 years ago, before we had gene expression profiling, but it closed due to poor accrual, but we may see this trial in order to address this remaining knowledge gap. Well, I told you that the clinical pathologic features still provide very useful information above and beyond the 21 gene recurrence score. How do we integrate that combine those two pieces of information to make better informed decisions? In order to address this, our group embarked on a project to develop this model that we call RS-CLIN, where we performed a patient-specific meta-analysis using data from some of the trials that I showed you for individualized prognosis and individualized prediction of chemo benefit. The factors, the covariates we used, included the 21 gene recurrence score, tumor grade, size, and age. And we performed this meta-analysis using Cox regression of previous trials for the log cumulative hazard estimate for prognosis for 10-year distant recurrence rate. And we combined this with Cox regressions for chemotherapy benefit to estimate chemo benefit. We then performed, once the model was developed, we performed external validation to compare the RS-CLIN risk to the observed distant recurrence risk in a real-world experience in a registry in Israel. And what we showed here is that the RS-CLIN provides more prognostic information than clinical pathologic features alone or the recurrence score alone. Shown here are the likelihood ratio chi-square, which captures the amount of information provided by a model, and the likelihood ratio test, which compares the amount of information provided by the two models. When the RS-CLIN is compared to clinical pathologic features alone, the likelihood ratio test favors RS-CLIN. And likewise, when the RS-CLIN is compared to recurrence score alone, it also favors RS-CLIN. Therefore, the likelihood ratio tests confirm that the RS-CLIN model provides more prognostic information than either the clinical pathologic variables alone or the recurrence score alone. This graph shows the external validation, and it shows the average RS-CLIN distant recurrence risk for the cohort in blue compared with the actual Kaplan-Meier risk estimate observed in the cohort shown in quintiles. And as you can see, the risk estimate provided by the RS-CLIN tool was significantly associated with distant recurrence rate with a standardized hazard ratio of 1.73. And furthermore, the calibration plot on the right demonstrates a Lin concordance correlation of 0.962 between the distant recurrence risk estimate provided by RS-CLIN and the actual outcomes in this population. And then finally, in order to distinguish prediction versus prognosis, we calculated the RS-CLIN 10-year distant recurrence risk in what we call a clinical low risk and a clinical high risk scenario described here on the top of each curve. The two figures show the RS-CLIN estimated absolute chemo benefit in a typical clinical low and high risk scenarios for 55-year-old woman, and is shown in the black solid line representing the RS-CLIN estimate compared with the red dotted line indicating no prognostic or predictive effective recurrence score. And this is a counterfactual. The RS-CLIN estimated absolute chemotherapy benefit varies widely, with a recurrence score ranging from 11 to 50 in both scenarios, from both 0 to 15% in the low risk group and 1 to 33% in the high risk scenario, as shown in the table below the figures. And this is much a narrower estimated absolute chemo benefit in a hypothetical scenario, a counterfactual scenario, where the chemotherapy benefit hazard ratio is held constant with a varying 21 gene recurrence score. So this, I think, modeling provides and distinguishes the predictive versus prognostic information provided by the 21 gene recurrence score. And how does this apply to a real world patient? Well, if you had a typical 55-year-old patient with a 2-centimeter tumor and intermediate grade histology, without the recurrence score, you would estimate this patient might have about a 7% or so recurrence score, risk of distant recurrence without the recurrence score information. But here you could see with a recurrence score of 10, 20, or 30, the 10-year, these patients would have, this patient would have very different outcomes. The 10-year distant recurrence rate with endocrine therapy alone would be 4, 7, and 11%. And the estimated absolute chemotherapy benefit would be 1% or less for the low risk scenarios, but 6% for the high risk scenario. I'd like to move on now to show other examples of precision through and discovery through secondary analysis of clinical trials. And in this secondary analysis of this trial, we looked at patients who were cancer-free 5 years after diagnosis and did a simple blood test looking for the presence of circulating tumor cells, which we found in about 5% of the patients. And these patients had about a 13-fold higher risk of recurrence. We also looked at the presence of circulating cytokines in the blood at the time of diagnosis using a discovery-based platform and found that serum IL-6 was prognostic for early recurrence of breast cancer. The take-home message here is that we may be able to further refine a prognostic utility and biomarkers through the application of other biomarkers added to the ones that I've already shown you. Well, I've shown you before that distant metastasis is the primary cause of death despite local presentation and local therapy. I've also shown you that more aggressive therapy, such as mastectomy, does not reduce recurrence. And there's this continued risk of recurrence beyond 5 to 10 years, especially in ER-positive disease. I've also shown you that biomarker-directed adjuvant systemic therapy reduces recurrence risk and breast cancer mortality, including endocrine therapy for the 70% of patients with ER-positive disease, anti-HER2 therapy for the 20% with HER2-positive disease, and chemotherapy in high-risk disease. But some are cured with no therapy, and others are not cured despite therapy. And so one fundamental problem here is that there are no biomarkers that reflect the underlying metastatic process, and there's no treatment that can block metastasis. So one strategy would be to advance precision through science by better understanding the mechanisms of metastasis. And I'll present to you one mechanism here. And this is the discovery of the tumor microenvironment metastasis, so-called TMEM, which my colleagues at Einstein believe is the doorway for metastasis. And this was demonstrated initially with intravital imaging using fluorescent labeled cells in a PYMT model. Here you see dextran red within the blood vessel, and you see green tumor cells in the interstitium, and you see these blue macrophages that are adjacent to the blood vessel and right next to a tumor cell. And this tripartite structure is we've dubbed the TMEM, and we believe is the point of entry in tumor cells into the circulation. And in this PYMT model, you can see this green tumor cell when it is now superimposed on this blue macrophage, it now appears yellow, and you now see these green tumor cells in the circulation. And conversely, as these tumor cells are entering into the circulation, you see dextran red exiting into the extravascular space. And so you see this bursting phenomenon at these TMEM sites in this PYMT model. And in this model, it was demonstrated that the tumor cells enter the circulation at around the same time that this bursting phenomenon occurs. Well, it turns out that one can identify these TMEM structures by using a triple immunostain for CD68 to identify macrophages, CD31 blood vessels, and a pan-MENA antibody that can identify this subpopulation of invasive tumor cells. And where these three cells are in direct contact is called the TMEM structure. And this has been shown to be prognostic in ER-positive breast cancer in 3 independent cohorts involving about 1,100 patients. And it's significantly higher in ER-PR negative disease, which we know has a higher risk of recurrence than ER-positive disease. It's also been shown that the TMEM are present in lymph nodes and distant metastasis in human breast cancer. And in this vignette of a patient that I treated quite some time ago who had early stage breast cancer and a low recurrence score, treated on the TAILOR-X study, who developed lung metastasis 7 years later, we showed that the TMEM were identified in the lung and that the primary tumor had a high TMEM score, explaining the conundrum of why this patient with a low recurrence score relapsed. We also showed in a prospective validation study involving nearly 300 patients who had ER-positive, HER2-negative breast cancer with 0 to 3 nodes who were treated with adjuvant chemotherapy and for whom we had recurrence score information, that the TMEM score provided independent prognostic information for those who had a mid-range recurrence score, especially if you compared high versus low TMEM density. There was a 4-fold higher risk of recurrence. We also demonstrated that in patients treated with neoadjuvant chemotherapy, if you looked at TMEM density in the primary tumor before therapy compared with after chemotherapy in residual disease at the time of surgery, with the red line indicating a high TMEM density associated with a higher risk of recurrence, you could see that in the majority of patients, there was actually an increase in TMEM density in the residual tumor. The graph on the right shows that this difference was statistically significant. We then went from the bedside to the bench and tried to recapitulate this in animal models. And we demonstrated that that chemotherapy in this model increased the TMEM score and circulating tumor cells, despite decreases in tumor size in both the PYMT and PDX models. So 4 different models demonstrating an increase in TMEM score in the primary tumor and an increase in circulating tumor cells, despite the fact that the tumors were actually decreasing in size. So the take-home message here in our interpretation was that as the tumors shrink, they may become more efficient in disseminating tumor cells, which we believe is a previously unrecognized mechanism of resistance to cytotoxic therapy. So how do we overcome this? My collaborators pursued a strategy of targeting TIE2, the TIE2, and using a TIE2 kinase inhibitor called ribacinib, which we believe can block TMEM function, intravasation, and metastasis. This blocks the TIE2 receptor on these TIE2 high, VEGF high subpopulation of macrophages that are part of the TMEM structure. Upon release of angiopoietin 2 by the endothelial cell, this binds to the TIE2 receptor, triggering release of VEGF, which then causes the endothelial cells to contract. And when they contract around a rigid TMEM structure, this opens the door to allow tumor cells to intravasate to the circulation and here red cells to burst into the extravascular space. In this preclinical model, we've demonstrated that the TIE2 inhibitor ribacinib can decrease the amount of dextran bursting and can also decrease the amount of circulating tumor cells in the blood, and can, when added to chemotherapy, reduce the number of lung metastasis. Here you see lung metastasis on the left in an untreated animal, and after treatment with ribacinib, blockage of reduction in the number of metastasis. And you also see an effect on the primary tumor, possibly through its anti-angiogenic effect. So based on this, we performed a first-in-human trial combining ribacinib plus anti-tubulin therapy using this drug ribacinib, which was initially developed as a BCR-ABL inhibitor and used in leukemia. And it was found that it wasn't a great leukemia drug, but it's a very good inhibitor of Tie2. And in this study, it was found that there was an increase in angiopoietin-2, which is a pharmacodynamic biomarker of Tie2 blockade. When we used this with paclitaxel or Rivulin, we saw in some patients striking anti-tumor effect. This is a patient with a large fungating breast mass, which completely resolved with therapy. And we saw pharmacodynamic effects with decreasing circulating tumor cells and increased angiopoietin-2. We also saw a dose-dependent effect of an increase in ocular pressure. We saw this with the 100 milligram dose of ribacinib compared with baseline in the orange here, and a lesser increase in intraocular pressure at the 50 milligram dose level. Why is this? And is this a pharmacodynamic biomarker? Well, it turns out that Tie2 is located in epithelial cells of the Schlemm's canal. Deletion and that deletion of angiopoietin 1 and 2 in Tie2 adult mice results in severely impaired Schlemm canal integrity and transcytosis, resulting in increased intraocular pressure, which is a hallmark of open-angle glaucoma. So this might be a pharmacodynamic biomarker that we can use, and we're currently pursuing other inhibitors of Tie2 that may have less off-target effects compared to the ones we saw in our phase 1 trial. Finally, I'll conclude with equity, a discussion of equity, and certainly the COVID-19 pandemic has uncovered racial and ethnic disparities in healthcare outcomes. As you can see here, mortality rates for Blacks or non-Hispanic Blacks or African Americans and Hispanics or Latinos is substantially higher compared to COVID-related mortality for whites. And in our experience at Montefiore, nearly 6,000 patients who presented with COVID over a 1-month period of time, of whom 16% of patients succumbed, we found that Hispanics and non-Hispanic Blacks had substantially more comorbidities than non-Hispanic whites. And after controlling for age, gender, socioeconomic status, and comorbidities, comparing with non-Hispanic whites, there actually were somewhat lower mortality rates in Hispanics and non-Hispanic Blacks, indicating that that addressing these disparities and comorbidities could help result in better outcomes. We also saw a very high case fatality rate early on in the pandemic for patients with cancer, posing another barrier. Well, these racial disparities are well known and well documented in a variety of cancer types, but particularly for breast cancer. And as you can see, and as I showed you before, cancer mortality rates are declining substantially over the last 40 years, but there remains this racial divide between Blacks and whites. And there are many reasons for this. And this includes more advanced stage presentation, higher rates of triple-negative breast cancer, more lethal form of breast cancer, higher obesity rates, more comorbidities, disparities in care, and other social determinants in health. And certainly addressing these social determinants of health are necessary, but is it really sufficient for addressing some of these disparities? Well, there is some evidence that at least in estrogen receptor breast cancer, it may not be, because we seem to consistently observe racial disparities in estrogen receptor positive breast cancer in clinical trial cohorts. And we focused on clinical trial cohorts because these are patients who are healthy enough to participate in cancer clinical trials, have access to good health care, and are getting state-of-the-art care in the context of a clinical trial. And when we looked back at racial disparities and outcome in one of the trials I initially showed you that showed the value of adjuvant paclitaxel, 8% of these patients were Black. These patients had stage 2 to 3 disease. And we saw about a 1.6-fold increase in recurrence risk, specifically in Black women who had ER-positive, HER2-negative disease. This was by self-identified race. And we did not see this in other healthcare, in other breast cancer subtypes. We saw the same thing in another study where patients received chemotherapy. Here, there was a 1.5-fold increase specifically in ER-positive, HER2-negative disease, but not the other subtypes. And this was in patients who had African-American ancestry defined by ancestry informative markers. We then looked at the TAILOR-X population. Again, these are patients who had the lowest risk disease, ER-positive, HER2-negative. They all had the 21 gene recurrence score. And here we also saw racial disparities by self-identified race. We then looked at our cohort at Montefiore Einstein, where about a third of our patients were Black. And here we saw a 1.8-fold increase in risk specifically in ER-positive, HER2-negative disease, not the other subtypes. And we also looked at the National Cancer Database. And here we see a 1.25-fold increase in mortality by self-identified race. When we took a deeper dive into TAILOR-X, we found that these racial disparities were not explained by earlier discontinuation of endocrine therapy, clinical pathologic characteristics, differences in the 21 gene recurrence score, insurance coverage, or the neighborhood deprivation index, indicating there's something going on here that we can't put our finger on. In order to address these disparities, we've initiated a trial, which is now nearly complete, where we try to address the neuropathy that seems to be taxane-induced neuropathy, which is a major side effect of taxane-associated adjuvant and chemotherapy. And we previously demonstrated that women of African-American ancestry, and this is with ancestry informative markers, are more likely to get grade 2 to 4 neuropathy from taxane than women of European-American ancestry, and they also had worse outcomes. And we've identified specific genotype associated with a higher risk of grade 2 to 4 treatment-associated neuropathy, which can be distinguished from a low-risk phenotype. And we've now nearly completed a accrual of about 240 patients in this NCI-sponsored trial for patients receiving one of two types of taxane therapy, where we're attempting to prospectively validate the ability of this germline predictor of Taxol-induced neuropathy to identify patients of African-American ancestry who are most likely to develop neuropathy. The notion here is that we might be able to use this genotype to direct patients to a specific type of chemotherapy associated that they may need to help reduce their breast cancer recurrence, but use a type of chemotherapy that may be less associated with neuropathy. So this is my final slide, and it concludes the history of the progress and precision in localized breast cancer in 1976, when Dr. Bonadonna made his first seminal report compared to today. At that time, screening for breast cancer was not a proven value. Local therapy consisted of mastectomy and axillary dissection. There were no systemic therapies that were proven to be of value in reducing the risk of distant recurrence, and there were no biomarkers. Today, we have effective screening tools such as digital mammography in average risk patients, or MRI in high risk patients who have genetic mutations that can identify breast cancer that's early stages of disease, where it's more amenable to cure with local therapy alone. We're using less surgery rather than mastectomy. We're using wide excision and sampling 1 to 3 sentinel lymph nodes rather than doing level 1 and 2 axillary dissection, which is associated with less morbidity. And we're using better radiation techniques, treating either the whole or partial breast, which results in better local control without sacrificing local control and lower long-term toxicities. We now have a slew of systemic therapies that can help reduce the risk of systemic recurrence, including anti-estrogen therapy, chemotherapy, anti-HER2 therapy, immune checkpoint blockade, and coming down the pike, antibody drug conjugates. And we now have biomarkers that can identify tumors that express ER/PR and HER2 that can guide the use of adjuvant endocrine therapy and HER2-directed therapy. We can identify germline biomarkers that are associated with increased breast cancer risk that might identify patients who can have prophylactic surgery, prophylactic mastectomy, or oophorectomy to markedly reduce the risk of developing cancer in the first place, or guide the use of adjuvant therapies such as PARP inhibitors. We also have somatic gene expression assays that can guide the use of targeted therapies such as PIK3CA inhibitors, which I did not get into. And finally, we have blood-based biomarkers such as circulating tumor cells and circulating tumor DNA, which we can use for surveillance or guiding the use of systemic therapies in patients with advanced stage breast cancer and in the future, early stage breast cancer. Thank you for your attention.
Thank you very much, Dr. Sparano. This is a terrific talk, and coming from 1976 to 2022, we've got a lot of reason for optimism thanks to you and your colleagues in this terrific work. There are already a couple of questions in the chat. Dr. Greenberg starts off with, has anyone seen enough male breast cancer patients to compare with female patients in any of these areas that you've described?
Well, for every 1,000 with breast cancer, there's one man who develops breast cancer. I have a number in my practice now. Breast cancer in men tends to occur in older men, more likely to be estrogen receptor positive and HER2 negative, very, very not infrequently, I should say, associated with germline, pathogenic germline variants in the BRCA2 gene. Otherwise, the principles of management of male breast cancer are quite similar to the management of breast cancer in women, with the exception that for anti-estrogen therapy, tamoxifen is really the preferred agent compared, say, with aromatase inhibitors, which cannot be used in men without the use of gonadotropin analogs, which can induce significant morbidity.
And Mike's second question, has anyone compared two or more of the gene platforms in the same patient?
That's an important question. Yes, they have been used. It's not uncommon that if patients have a high recurrence score, they may have, say, a mammaprint assay, a 70-gene assay as a tiebreaker. In those circumstances, I think it's important, and as I've shown you, and I just briefly touched upon it, there are several gene expression assays that have been shown to provide prognostic information. The 21-gene recurrence score is the only one that seems to show predictive information for chemo benefit. That may not just be a function of the assay itself and what drives prognosis and prediction in the assay, because most of these assays are really driven by estrogen receptors reflecting estrogen receptor signaling and proliferation, but may be a function of the populations that they were validated in. Getting access to these clinical trial cohorts is very challenging, and there are very few of them. And the ones that provide most value are the ones where patients were randomized to one treatment or another treatment. So I think the most important take-home point is, number one, these assays do not classify patients in the same way as high or low risk. Point number two is that fewer patients are classified as high risk using the 21-gene recurrence score. It's about 20% compared with the other assays, which is in the range of 35 to 40%. And if the purpose of using these assays is to spare the use of chemotherapy, obviously one would want to use it in a population that assigns the fewest patients to the high-risk category. And thirdly, if one is going to use these assays for guiding the use of chemotherapy, my opinion is that one should use the assay where there's the highest level of evidence supporting their intended use. So that's an indirect way of addressing that question without calling out a specific gene expression assay.
Okay, a couple of typos in the next one, but I'll take a crack at it. Does obesity of postmenopausal women show increased recurrence and invasion of estrogen and macrophages?
Yeah, that's an excellent question. One of the points I tried to make in the talk is that oftentimes, we design a prospective clinical trials that are done in the NCI system to address a specific question. But oftentimes we learn more from the secondary analyses from those trials. And I showed you a couple examples of those. About 10 years ago, we published a report in the same trial that I showed you earlier, the E1199 trial, demonstrating that obesity was associated with a higher risk of recurrence, which wasn't a new observation in early breast cancer because about 40 previous studies had shown that. What was different about our result was that we identified an interaction between obesity and higher recurrence rate in ER-positive, HER2-negative disease. That report, which got a lot of attention, then triggered a meta-analysis by the Early Breast Cancer Collaborative Trialist Group. And in this meta-analysis, including about 100,000 patients, we found a very similar interaction. That is, an interaction between obesity and high recurrence rate, specifically in ER-positive, HER2-negative disease. The reason, and more so in younger patients than in older patients. And that may be for several factors. There may be inflammatory cytokines that are driving this. IL-6 is an example of an inflammatory cytokine that I showed you that's associated with higher recurrence rate. And there may be multiple factors, other factors such as estrogen and, say, hyperinsulinemia that could be driving this. Regarding the macrophages, I've shown you a potential essential role of macrophages and in driving metastasis. And this is a major area of investigation now of therapies that are targeting macrophages to try and prevent metastasis. I also see a question about TILs or tumor infiltrating lymphocytes. Those have shown to be prognostic in localized triple negative breast cancer. Higher TIL expression is associated with a better prognosis. However, because of issues related to analytic validity and reproducibility, these have not yet been integrated into the prognostic classification for early breast cancer.
All right, we're actually past the end of the hour. So if anybody has to leave, please do, but we'll try to get this last question from Dr. Chen answered by Dr. Sparano. How are the activated macrophages participating in the metastases? Does Tie2 inhibitor target the tumor, or is it mainly interfering with macrophage response?
Yes, I showed you the example of our efforts to do exactly that using the drug Rebastinib. It turns out that that drug, which binds to the Tie2 receptor on this Tie2 high VEGF high macrophage, and had the clinical effects that I showed you, including pharmacodynamic effects with reflected by increased intraocular pressure. That drug also had off-target effects. It hits the tencarases, and because of that, it was associated with musculoskeletal toxicity. So the company that's developing that drug is developing a second-generation Tie2 kinase inhibitor that has less off-target effects on the tencarases, and we hope to be pursuing clinical trials and resuming that therapeutic strategy.
Okay, well, thank you so much, Dr. Sparano, for this terrific talk and update, and we look forward to hearing more again in the future.
Thank you for the opportunity to share my work.
All right, be well, everybody. Thank you.